Thanks everybody for being so prompt and on time. It's terrific. So I'm just going to get started so we have enough time. So we have time for discussion and other things, but remember that you can type your questions or raise your hand at the end. We'll have some time, and if you have some questions or troubles with your computer, please, or the webinar, contact Sidoni at the email that you see there. And the session is recorded and will be posted on the BC Renal website after the morning. Next slide, please. So I'd like to reflect that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. This includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region, and all of you around the province or other places in this country are respectfully understanding and learning more about the place and space that you live in. We, as always, endeavor to be respectful in all of our interactions with people and the land, and are very grateful for elders past, present, and emerging. Next slide. So Province-Wide Rounds, as you know, is a collaboration between UBC Division of Nephrology and BC Renal. It's generously for and by many of us around the province in all the different health authorities, and also sponsored or facilitated by our industry partners listed there. And this is really a unique thing. And I think although we didn't used to have province-wide rounds before COVID, this is the one thing I think that has really brought the province together in a different way. Next slide, please. So today we're going to hear from Dr. Kris Poinen. He's a clinical nephrologist in Victoria, BC. He's a clinical assistant professor in the division and completed his UBC medical school in Vancouver, his internal medicine residency at the University of Calgary, and then returned to UBC for his nephrology fellowship. He's gone on to complete the UBC Home Therapies training program, which is a collaboration between BC Renal and UBC, and also completed a master's degree in health administration and the Excellence in Quality Improvement Certificate program from the University of Toronto. His major interests are in home dialysis therapies, quality improvement, and spending time with his young family. And so, Kris, thanks very much for giving us a crash course, perhaps, on improving the journey home for Acute Dialysis Starts, about your crash cook and feasibility project. So thanks very much.
Thank you, Adira, for that introduction. So I'll just share my screen here and we'll get started. So as I'm presenting to you from Victoria today, I also would like to acknowledge and respect the Lekwungen peoples whose traditional territory I'm presenting from, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationship with the land continue to this day. And so that was a great introduction, as it does lead me to my next slide, which is home. This is where we have the comforts of this common environment, surrounded by loved ones, and have these simple comforts, including joys. One of which more recently has been when I come home, I build Lego with my son. And so that's been a bonding experience and something I look forward to. And I think it's these simple pleasures that we benefit from being home, and equally with our patients, and affording them a chance to have the ability to stay at home and receive their treatments at home truly is of benefit. And so that leads me to this discussion and where we embarked, which is improving the journey home for patients. And so this brings me to the project itself, which is the curriculum for recruitment of acute starts to home dialysis therapies, which is essentially a crash project summary, albeit there's a little bit more of a background and a backdrop that I want to build today. And so let's just jump right in. The learning objectives for today are to describe and understand the challenges faced by acute starts, especially when it comes to transitioning to home therapies. Secondly, to understand the potential benefits of a structured curriculum focused on modality education and assessment on these transitions to home therapies amongst this particular population. And then finally, and thirdly, we looked at identifying opportunities for which we could expand and implement this curriculum provincially to improve, hopefully, home therapies rate down the road. So as I was starting with this presentation and trying to group my thoughts, I kind of did some of those back of the napkin notes, and this is what I came up with. In essence, I'm looking here at the fact that home therapies are beneficial, but that the rates are currently stagnant. That home therapies really comes from the rates, comes from ins versus outs, which looks at recruitment versus attrition. And we know that we've had both good attrition through transplant and some untowards attrition that we're still working upon. And I chose to focus on recruitment to see if there were who would be amenable to home. And so that led us down a path where we looked for missed opportunities to home therapies, which is another project we did. And we found that there were. And so then we said, why may that be? And it was found to have a lack of specific home therapies education and some delays within the process for assessment and looking for contraindications. We'll go into this a little bit more depth. Further, if we look at this vulnerable population, which is the acute starts, we realize there's a period of stabilization, there's heightened anxiety, there's that lack of pre-dialysis education, and within that acute component, there's delays within the current process that we have, and it's very case by case. When we look at the curriculum, in summary, it is looking at a structured course of education, timely assessments, and holistic supports through mainly the navigator role, which we'll delve into a bit more. So therefore, a simple math would be if we had these acute starts and we applied this curriculum, then we would be looking at further recruitment and then further home therapy transitions. So we know that home dialysis therapies are beneficial. And why is that? Well, we know that it allows patients with more flexibility in their treatment and their time. It also decreases the transportation and logistics around receiving their treatments. We also know that through longer dialysis, more frequent dialysis, continuous dialysis, there's better biochemical and clinical parameters that can be achieved, such as blood pressure and clearances. There's also perhaps even more energy and robustness, which allows patients to do more things at their time, especially when scheduling work and schooling. But more importantly, in the middle here, it gives patients autonomy and it allows them to have that freedom and choice and a little bit more of a hands-on approach to their care. So we know that there's benefits of home therapies. So we know that in BC, and this is just one graph that you may be very familiar with, is that we have the bar, which is set at the 32% there. And within the province, this looks similar across the board. But an example is that, in BC, we do not too bad from a home therapies perspective. The question is always, how do we meet that bar? And could there be a room for improvement? And so we also note that the rates have generally been stagnant or similar over the past few years. So is there any ways to budge that? And so the first question I asked were, are there actually a population where we could tap into and see if there was further opportunities to recruit to home? And so that led us to this particular project where we looked for missed opportunities previously. And here we looked at over 2,700 patients over preceding 2 years, so retrospectively, and we looked at chronic incident patients with pre-dialysis care. And 1,800 met the inclusion criteria, of which 320 were deemed missed opportunities. Well, what does that define as? Anyone who may have chosen a home therapies or were undecided and ended up on in-center hemodialysis ongoing. And so that's 320 patients with the preset dialysis care. We also found that with the documentation, and again, this is limited by the data collection, we found that there was only 5% of the cohort who were absolutely contraindicated to both BPD and home hemo. Further, we found that when we looked at those who were missed opportunities compared to those who went on to home therapies or an acceptable therapy, it was felt that there was a lack of specific home therapies education provided to those particular patients in the missed opportunity group. So we can also see that even with a robust home first program with multiple supports and pre-dialysis care, that there's even some opportunities where we can perhaps improve upon. And interestingly, in the 910 patients which we excluded, which is those who had started acutely or those without prior pre-dialysis pathway care, you can only garner that this is even more emphasized, and the detriments from not having that education. And as we mentioned already, the acute start process. So with recruitment specifically, we looked for missed opportunities. We saw that there were pockets, and that some of the barriers were the inability to have that home specific education, and that there was perhaps some optimization in how we assess these patients and apply the contraindications. So with that, I want to jump into the first learning objective fully, which is what do these acute dialysis start population look like, and what's limiting their transition to home with this backdrop. So we know that through literature and through our own observation that end-stage kidney patients who start dialysis with little to no pre-dialysis care or an acute start, the patient journey is not well characterized. There's also various definitions applied, so it makes comparisons even more difficult globally. We also know that they comprise a significant portion of incident dialysis starts, and that they are frequent, and that they're associated with higher morbidity, cost, and mortality. There is also an initial stabilization period. The patients are newly diagnosed, they're new to the treatment, so there's a period where we're optimizing their clinical parameters and adapting them to the treatment. We also know that during that time, this is all new, so there's also an anxiety level that is accompanying that. And equally, there's a sharp learning curve as they've not had exposure prior, and now they're going to a treatment and full bore. So the other item that we've noted is that if the longer exposure time you have to the in-center treatment and area and facilities, you're less likely to transition elsewhere. And so with all of that, we also know that there's lower uptake with home dialysis therapies in this population. So to surmise at the top there, acute starts, period of instability, there's anxiety, there's that lack of modality education prior to, specifically home, and there's delays in the process itself through the multifaceted barriers. So when we look at transitions globally, we know that modality transitions in whomever, it requires coordination and collaboration both between the patients and the renal team care team. And so it's very interwoven, and there's a lot of moving parts. And so, but we need to understand that the renal care team is also a great factor, and that their level of comfort, their capability of educating a patient on home therapies and removing biases is an important factor. We also noted that renal team members felt or perceived patients to be too anxious in these facets to pursue education. So all to say that these transitions, this population faced with multifaceted barriers, as I mentioned, therefore we would need multifaceted novel interventions to overcome these layers. And so there have been some in the literature looking at this particular population and potential interventions. And these come by through transitional care units, in-hospital modality education, and even early recognition programs. So part of it is that there's both pros and cons to all of these measures. Transitional units tend to have a good education program, but it is largely focused on a physical space. The in-hospital modality education was a very big bolus of information, trying to have patients lock in quickly. And then even early recognition tends to be more of a case-by-case basis. So looking for more structure as we move forward would be beneficial. So now we've gathered some of our pieces, some of the material that we can build upon. And so how do we go about this? And so that's where the CRASH project comes in. And so this was comprised of two parts, and essentially was a prospective observational study over this duration in adult dialysis, incident dialysis patients across 3 sites in the province from April 12th to November 1st, 2021. And what we did was we firstly looked at acute starts and quantifying and characterizing the acute starts that were occurring. And then secondly, we went about the creation of the curriculum and looking at the feasibility. So for this particular time, I'm going to focus on the acute start component. And so here, if we follow the branch points, we applied a specific acute start definition. We kept it very simple to capture as many people as we could, which was that any incident patient in this adult population who had limited, less than 3 or no pre-dialysis care. From there, we've followed them through their early few weeks, and we placed a general trajectory of their outcomes. And this included recovery of renal function to the point of not needing dialysis, them being deemed to be acutely unwell by the renal care team or consult team to the point that they may stabilize down the road, but not quite at the moment. 3 was that they were of imminent poor prognosis in a short time frame, and others would be relocating or transitioning to another healthcare region. And finally, we also applied criteria that would look at their capabilities of entering a future education program, such as the curriculum. And so with that, the curriculum criteria itself, as implied as above, is that we looked at all acute starts requiring chronic dialysis. They were deemed medically stable by the team. Patients were interested, and that there was no quick recovery foreseen. And through this, we measured their demographics. We measured some of the outcomes, as I mentioned, and quantified that over the 3 sites. We also performed a survey looking at both patient and renal team perceptions in terms of what they felt about the acute starts itself. So these are some of the results. Firstly, we looked at just how many acute starts did we have. And we found that there was 178 over this fairly short time frame over 3 sites, 178 patients that met that initial definition, of which we found that 78 went on to recover, so a good nearly half, acutely unwell with 34, imminent death or poor prognosis 22, 17 relocated, and we had 27 patients initially who met that curriculum or educational criteria. So that's a fairly frequent occurrence, 1 case every 2 days for this shorter duration of study. We also note that there was 15% of patients who were initially deemed candidates for the education program out of the 178. Yet when we consider that those who recover and those who are of imminent poor prognosis, they're not meant for long-term dialysis. And so if we looked at those who were more likely or higher need of chronic dialysis, we find that that's 27 out of 78, and which is about a third or 34% of those who would meet the criteria. And that's a good frame to remember the denominators that we use, and we're actually looking at patients who would be benefit from home and not necessarily looking at everyone on one go. And when we move on to look at the demographic parameters in this, we looked at those who were in the total and those who were in the curriculum, as can be seen here, the 27, and also looked at them to compare to those who did not meet the curriculum basis for whatever reason, and as well specifically the recovered function. And so I think that most parameters were similar, but it's important to note that the curriculum tended to be younger patients who were amenable and interested and willing to undergo, but also met the criteria. So interesting there. When we looked at the survey perception of patients and team members at all 3 sites, we asked specific themes, and one of which was just to see what level of comforts the patient had, which modality they were most comfortable with at the beginning. This is a pre-survey, so this is at the very beginning of the project itself. And so it was found here that unexpectedly or not surprisingly, that both the team and the patients were most comfortable with in-center hemodialysis. And this may be inherent. The patients, this is their acute start, so they have no prior experience likely. They are starting off on in-center hemodialysis, so therefore they're likely this is the most exposure point and the most familiarity that they have. Equally, it's also important to note that with the renal care team, majority of respondents were indeed in-center hospital nurses. So therefore, this is the modality that they work most with on a day-to-day basis and likely forms their comfort. And so it's important to just look at here and say that the other modalities are not as familiar and not as comfort for even the team. And so it works, it's a good place to say that there's areas to improve and further educate, as well as to try to bring these knowledge bases and comfort together. And so the next part is we looked at surveys where the respondents' perceptions of just the idea of further education and a specific program. So when we asked, would patients be interested in receiving education about their options? Would they like family members there? Would they like to meet with a specific person from the home dialysis team? What do they think about the ideas of doing dialysis at home right off the bat? And we can see with the dark blue and the darker orange bars there, which is strongly agree and somewhat agree respectively, that the majority of patients are open to receiving this education and, if anything, would want it. Equally, when we look at the team surveys, we found that, should they have a chance to transition, should they have a chance to home therapies, much like their pre-dialysis counterparts? Could there be improvements in the process currently? And would an education process be helpful? Once again, the dark blue and the dark orange here suggest that the team members were in favor of providing that information. So it looks like there's agreement in the potential for improvement. Now, interestingly, and one that I left off here, is the idea of anxiety. And what we can see here is that at the bottom, we can see that both the blue and the orange bars for teams were quite overwhelmingly that patients were too anxious to receive this information, albeit they did say an education may be a benefit as well. Whereas the patients were not wholly determined that anxiety is a barrier. And I think that it goes to show that this 50-50 nature of items it's understandable that there's anxiety, but not all patients perceive it to be that barrier that the renal team may see. So it's in a discrepancy that we can work upon. And if we identify patients who are interested, then there are patients who are willing to have this information. So that brings us to the initial discussion. As already stated, the acute starts are frequent. Their outcomes vary. Demographics generally same, but those who met educational criteria were of younger and higher rates of hypertension. It's also important to know that when we're delineating what our target should be for home therapy overall, is that we have an appropriate denominator. As you can see, we should be targeting a realistic population of those who will likely need long-term dialysis as opposed to just everyone. And we do want to map that appropriate patient to the appropriate modality. And so careful selection is important. We also found that the survey respondents agreed that the current process could be improved, and yet there were still some discrepancies such as anxiety of what we perceive to be barriers. So with that, we now have our building materials. We're starting to organize it. We're now starting to have more of a blueprint of what we do next and how we go about building this. And so that takes me to number 2, which is the benefits of a structured curriculum and focused on modality education assessment. So this would essentially bring us back to the CRASH project as a whole. We've now looked at the acute start branch, and so we'll focus on the curriculum itself. The creation of a curriculum, which came about with QI methodology, which I'll show you. We looked at resources and reframing some of the current resources that we have, and looking at our staff and how we may best deliver that, and emphasis on the navigator role here. Then we performed a feasibility project where we had 2 pilot or protocol sites with implementation and 1 control site to see what the current process would look like. Furthermore, we did surveys, both pre and post intervention patients and renal care team, to see what was the thought about the curriculum itself. So jumping in here, in terms of the creation itself, we did the normal QI methodology process. So some of these may seem familiar, including environmental scans, fishbone surveys, process mapping, looking at all the various members that are involved in the processes and looking at metrics. And so through that ongoing cycle, we came up with a 6-week program, 2 weeks of looking at initial stabilization and home therapies education, 2 weeks of more empowerment of the patient and including assessment of them for home therapies. And the third 2-week block was looking more at planning, documentation of how if they would succeed to home therapies if that was their chosen route. And so within that 6-week timeframe, now we built this upon existing programs, and that includes the transitional care units, the previous in-hospital education programs, but modifying it so that it's a bit more ubiquitous and a bit able to be applied in more settings. And one of the key focuses was the nurse navigator role in those health authorities where they are present, and just how we may be able to utilize this role to better deliver the education that we're suggesting here, the curriculum. It's also important to note that we created various tools specific to the curriculum itself, such as an education package, such as standardizing the Match D assessments, and then the final documentation is with game plan of how a person who is approved for home therapies physically gets to the home therapies. And we did this by using the current resources that we have in BC Renal and then just regroup them in a more selected fashion. So they'll help with resource management as well. And lastly, I want to make mention that after the 6 weeks, the person was not meant to be on home therapies, but that they would have a plan and an approval for home therapies that we would enact thereafter. So looking at what we found from a result perspective, we found that, again, there's lots of numbers here, but I'll just highlight what I want for you, the audience, to take away, is that the general demographics amongst the pilot sites and the control sites were generally very similar, both in age and their comorbidities. And this is where I wanted to spend a little bit more time on, which is the flow of the curriculum itself. So when we looked at feasibility, we wanted to make sure that patients were flowing through the curriculum as we had anticipated. And so with the curriculum itself, we found that with just objective and mechanical nature here, we had 142 patients at the 2 pilot sites, as this is where the definition was applied and the curriculum was enacted thereafter, of which 23 met that criteria, and 23 went on to phase 1, which is the first 2 weeks of the 6-week program, of which we had 13 proceed to phase 2, and we had 11 proceed to phase 3, and we had 7 that eventually started home. It's important to note that we had 10 who were lost after phase 1 patients, 2 at phase 2 and 4 at phase 3. We also know that the duration in one of the phases and between phases was actually quite a range. So patients were either moving through quickly or spending quite a time within each of the phases beyond the 2 weeks that we initially anticipated. And I think that shows the need for flexibility down the road to adapt to these case-by-case changes. And we also note that 23 patients that met the curriculum in the same study duration, that's one person about 10 days who could meet the criteria and who would be entering the education program potentially. I also would observe here that if they were able to pass phase 1, that there's a much higher likelihood that the patient completes successfully the entire program. And I think that's after thinking and reflecting on it, it makes some sense. When we look at the breakdown for why people left after phase 1, which can be seen at the bottom here, we saw that there were still a few that were clinically unwell, but more so that there were people just making a choice of not continuing. And that could be through family or the patients themselves. And that's important as we are wanting to inform patients with this program. And if they so choose not to pursue the modality itself, then that's still a good outcome. It's their choice and with more information at hand. So I think that's a reasonable item. And we can also convert that to say those who were highly motivated at looking for home therapies, and we identified them early on, that they were much more likely to finish and have a plan and start home therapies. So that's, we also note that people were coming in and were coming out of the curriculum, and that there's still some areas to fine tune and optimize this flow as we move forward. So in terms of some of the curriculum outcomes, in what we want here is we were initially looking at successful transition to home therapies. And as I will allude to later on, there is obviously some limitations to our project, and part of it was just a small sample size. And that said, when we looked at the pilot sites, the 2 sites, we had 23 patients who met the criteria who entered, as I noted before. We had 2 who started a home therapies within the 90 days of that. And we had further 5 who eventually ended up on home therapies at the end of the study and review period. Again, albeit small numbers in the control site, there were no patients who had that successful transition to home. So some signals towards positive impacts even early on. So when looking at the patients, respondents, and their perceptions of what the curriculum provided, here I wanted to point out that we asked about the individual components and what that makeup of the curriculum would look like. But we also asked globally, what was your thoughts on the potential impact of this? And remember, I presented the pre-surveys here just to start. And I would say that overwhelmingly, albeit small numbers, patients were, at least 2/3, were in agreement that having such a curriculum, such a standardized education and assessment would provide the needed information, important home therapies information, that it would potentially help guide them to a decision about home therapies. And they also felt that, more so the educational package, which we created with current resources such as transition guides, modality presentations, and then even forming those into electronically and COVID savvy items such as QR codes and iPads, which are cleanable, to provide that. They would find that beneficial. Again, about 2/3. So signals towards that patients were willing and open to this. Equally, from a renal care team perspective, there was, and I should mention that green and light green would be very comfortable or somewhat comfortable. So we're looking at this as positives towards the questions and the curriculum. So we found that the teams felt that early modality education for Acute Start specifically, there was at least 68% who were in favor. They felt that a curriculum such as this would also inform modality decisions. They felt that it would be better set to identify appropriate home therapies candidates, and that it would increase awareness of the various modalities, including home therapies, amongst acute starts. And here specifically, we listed some of the tools, and right off the bat, there were some signals towards that there would be benefit from having these tools available. I also feel that the perception was that these tools are new and they likely would benefit from more experience and time and usage of these tools. So to surmise, when we looked at the curriculum and we applied it in this fashion, we found that it was feasible to have this standardized curriculum for modality education and assessment, and the potential to increase home dialysis transition, as we did see some patients end up in the home environment after completing the course. We also noted that there was positive perceptions of both the impact and the tools used within the curriculum. Yet, as always, there's always some room to improve upon this and to to have more comfort about the usage and delivery of the curriculum. So with a project such as this, in an era as we have just gone, there was obviously a plethora of challenges that we were faced. And I think at the end of the day, it made for a more robust and flexible curriculum and project, but it took a bit to get there. And so things that we went through, much like everybody else who did projects during the COVID era, there was a lot of start-stop items. There was a lot of staff turnover. I think this was a good example of having a more ubiquitous delivery amongst the care team, but also understanding the value of having a champion such as the nurse navigator role to deliver this very specific curriculum. We also had some difficulties with the data capture. We had some smaller numbers and just making sure we have accurate capture and the definition and the comfort there. We also had, as these were some of the more novel changes, tools, we had to clarify and re-educate on how to use these tools in the current setting and also how to apply the curriculum as a whole. We also looked at we know the small sample size, which I mentioned already. And globally, we also had to work with a team and look at buy-in and so forth. And I would say that, having gone through this now and seeing some of the more current literature, which I was looking at recently, especially with a greater need, especially in the US, where they're looking at increasing their transplant and home therapies rate combined, there's also some emphasis on improving home hemodialysis via a transitional care unit. And this would be an adaptation and looking at the education program without that physical limitation, but we could be applying this elsewhere and to other populations. So that leads me to the fact that now we have our foundation and we can continue to build upon this. And so that leads me to my third objective, which is to identify opportunities for implementation and expansion of the curriculum provincially. And so I hearken back to my initial scratch notes on the napkin, and we've kind of gone through this as a flow, looking at home therapies, looking at potential areas of improvement, looking at recruitment for bringing people in who are appropriate for home therapies, looking at some of the barriers they may face, looking at one of the more vulnerable population in this setting, and applying a curriculum that hopefully mitigates the barriers and seeing that it's feasible, that there's perhaps even better ways to deliver it. And the hope is that with this combination, we can indeed improve home therapies rates down the road. So this one, is a slide most people have seen by now, and we see that the programs currently are doing well, and that the patient feedback has been good. There's some of the things I want to pick out is just that there's still an inherent need for ongoing communication with the patients and the care team, providing appropriate information and ensuring that there's access to this, including treatment options, and providing consistencies as the word here. So looking for more standardized, consistent ability to deliver that care. And I think this was a nice encapsulation of some of the items that we were aiming for with the curriculum, in that we're engaging patients, and if they are willing to proceed, we provide them with that education and curriculum. We have more standardized approach to the tools and delivery of that education. And we're just having multiple touch points, especially with the navigator role, where they have someone that they can lean on for questions, and be it small questions that they in their minds, or even larger discussions about options. And I think with that specific standardization, it helps to build on that quality of care that's delivered. And especially how we document and how we measure these moving forward as well. So ultimately, I would want the integration of the curriculum with some modification to either the entire curriculum or parts of it, broadly, with expanded application and ubiquitous delivery amongst renal care team, and then measuring it as we go. So from this, in terms of moving forward, we should be measuring our acute starts and learning more about their patient journeys and where we can intervene, and ensuring that they have equitable access to the care that those with pre-dialysis care have. Equally, the curriculum, we're looking at ways to modify it, understanding that there's flexibility of time, perhaps 6 weeks is not everyone, looking at application whereby there could be an extended population, including, beyond acute starts. We could apply this to those who have failing graft, failing PD modalities, or just a prolonged period of time from someone who had the pre-dialysis care and maybe they need a refresher course, and this could fill in the gaps there. We looked at the tools, such as I mentioned, education package, looking at standardized ways of looking at barriers and how we approach those and categorize them, looking at novel ways to deliver it, be it through QR codes and tablets on hand, and looking at the staffing roles as well. And here it was important that, along the way, one of the major limiters was we were finding that nurse navigators were a great resource to deliver this curriculum, yet they were not all available throughout the course of the study. And so that really hampered the ability to proceed. And so with that, I felt it was a nice segue to look at that specifically. And there are certain studies available looking at navigator role as a whole. And there was a recent systematic review, which looked at, trying to compare and contrast, especially in the renal world, for these navigator roles. And it was found that, it's hard to measure impact when there's so many definitions and so many different applications. But there was some signals towards benefits on the rates of hospitalizations, the uptake in PD, and even the workup rates for transplantation. These were mainly nurses, albeit there's a smaller subset of social workers and other various backdrop. This was mainly studied in CKD, in-center hemo, peritoneal dialysis, renal transplant, but not yet in home hemo. The duties of the role was mainly centered around navigation, education, counseling, and an emphasis on this holistic support there, be it counseling patients through barriers, speaking to them, building rapport, speaking to family members, and kind of bridging the gap. And one study describes them as the puzzle master, and the ability to see and sort these different pieces together and kind of link everything at the end of the day. So I think this is an appropriate description. Albeit we can look further into patient experience and the cost effectiveness of these roles. I think we're already showing in the previous surveys that patients would be willing and open to speaking to someone such as this off the bat. So I think that's a positive. There's also a focus on marginalized and vulnerable groups inherently. And I think the acute starts would fit that criteria. But there's also other pockets within our renal patients that we could also help with this role. So moving forward, the authors and in general, is how do we best utilize this navigator program, especially with other interventions that may be in the nephrology realm itself. So maybe as a potential for a crash 2.0 or down the road, I think we started changing our lens and how we look at this problem, and how we look at improving more so the quality improvement aspect of things. We have a process that's generally working, it's achieving what it can, and how can we improve upon this? And part of this, as we move forward, was we have the curriculum, we have that building blocks, maybe to unlock it more and lock the path towards better utilization is through those champions and having a nurse navigator specifically. And here we would be looking to standardize and define the role of a nurse navigator and ensuring that there's an integration of the curriculum itself within that set of duties so that there's dedicated time and funding for that to be delivered. And I think with that, you have a more consistency and standardization. And as this is a fundamental process, and we're looking at it's some potentially looking at is that that's a big undertaking, and we would have to have various, making sure that it's optimized, making sure that there's buy-in, and making sure that it's feasible everywhere across the province. And so that would include inherent fundings, and we do think that with, albeit at the forefront, there will be some amounts needed for this. We could likely offset it with patients transitioning to home, which is ideally a more cost-effective modality. And as such, if we have that and we are able to look at these roles and show like for a business case that we can implement it at a few sites and that there would be benefits elsewhere, then perhaps we can look at more integration and ensuring sustainability long-term for this type of curriculum and its delivery. So that brings me back full circle to home. And I feel that there are some inherent benefits to home therapies. We know and we all enjoy the comforts of home, and our patients do as well. And through this embarking on this project and going through the studies, you find that there are inherent benefits. There are patients who would benefit from home and that we are better able to identify and coach them through this process and assess them. And if they are appropriate for home, then we have avenues to get them home. And so I look forward to working with everyone and the various team members that I have had with me on continually improving the patient's journey home. And so with that, and with hopefully some time for discussion, I will end here.
Thank you, Kris. Can everyone hear me okay? There are some questions in the chat. That was a great overview of a journey, and it really is a journey home, but also a journey through the different aspects of trying to implement something novel, right? So a few questions in the chat, which I'll just read out. What did you learn about the availability and role of the navigator and triage nurses around the province? I think you alluded to this, but for successful implementation, there's going to have to be some consistency of that role to deliver it. Perhaps a corollary question also from Dr. Copeland is, from a staff perception standpoint, how do you make a sustainable impact given all the turnover and burnout? So maybe you have some thoughts about that.
Yeah, good questions, and one we readily faced. I think we saw the importance of having that champion and that linkage for the navigator nurse on. We also noted that the lack of the nurse navigator really quite derailed the ability to deliver this optimally. And so I would say that having an appropriate, it starts with having the role and responsibilities well defined, and having the funding and the embedded role for the curriculum within that. And I think that will allow the particular role to know exactly what is expected and how it's to be delivered. And it also allows for ongoing growth within that particular role. In terms of the current environment, we do know that there are one or two health authorities which do not have access to a nurse navigator role. We also know that certain health authorities, each health authority which has a nurse navigator has it in a different facet. Some are essentially full-time, some are part-time, some are available on specific situations and days, and some of the focus has been different as well. Some are focused more on transitioning to community dialysis, some are more transitioning to home. And I think in the heart of the role itself to begin was looking at those potential transitions to other modalities, including transplant, including home therapies. So this is more of a recircling back to what the focus had been. And I think by inherently building this into the role and ensuring that the delivery of the care is being funded, there is a sustainable aspect to it, in the sense that there's more fulfillment, especially seeing that patient throughout their journey and seeing the endpoint, a concrete endpoint of them going home. And also just with the standardized description, I think that having staff turnover, which is unfortunately quite readily occurring, is that we can fit someone to that role because the description is very standardized. By also looking at the standardization of the curriculum, it's not fully burdened upon one person. It would be championed by the nurse navigator, but we're trying to make it more ubiquitous, that education tools and things like that are available to frontline nurses, hemodialysis nurses as well. So we can start the process and then backed up by the nurse navigator. And I think that both helps communication amongst the team members, but also allows us to kind of spread out the responsibilities and hopefully decrease the burnout from that.
Great. Now, Dr. Schwartz has a question, but Mike also has his hand up. So maybe I'll just ask Dr. Schwartz's question, circle back, and we'll take Mike off mute, and Marie Michaud after that. And so I'm going to try and combine some questions, the education, so Daniel was saying of the 178 crash starts, how many stayed dialysis dependent? And of those, what percentage went on home versus in center? That's the first question. You may not have those numbers at your fingertip. And the other question is, was the patient's primary physician part of the education or provide a patient recommendation? And what value might that have? And a corollary of Sherry's question is in terms of whether or not there's an education strategy for all the direct care teams on the basics of home therapies and its benefits, so that it's not just coming from one place and no one else is aware of it. Kind of a lot, but they're kind of all linked together. You can see them, right?
Mm-hmm. Yeah. So to start, the 178 patients were all, now if you start teasing out the recoverables, those who were mainly a poor prognosis, you're left with 78. The 27 went through the curriculum, and so we did not actually follow the acutely unwell, just due to the logistics and the abilities of what we could do. But of those that we followed were the ones that went on into the 27 that I showed you, and the 7 that did end up on home therapies. The rest remained on in-center hemodialysis. A few transitioned to community, and those are the attritions from that the path. So those who chose not to proceed essentially ended up on in-center hemodialysis. And the few that became unwell were also our losses. And so the percentages of patients on home were small from the 178, which we had 142 at the pilot size, 23 that went into the curriculum, and those are the ones that we followed until the end. In terms of, was the patient's primary physician involved? Just because of the uniqueness of the different sites, we did not have a built-in process for the primary nephrologist or physician. They would be welcome to be part of the curriculum itself. There are avenues for that in the discussion, but there was no specific item. This was mainly for those in-hospital consultation team, then that could be different personnel. And then once they're in the curriculum, the navigator may reach out, or the patient would be open to reaching out to their primary nephs for their advice as well. In terms of, if I'm reading this correctly, the education strategy for teams specifically, so that's inherently with some of the surveys, if I'm understanding the question correctly, is that there is a level of comfort that we can still work upon through all renal care team members about home therapies. And I think continual education and having sessions geared towards that, which we did ask in one of the survey questions, and there was an openness to receive more information about home therapy specifically. And I think that having continual touch base over time, especially looking at barriers, and what we perceive to be barriers may not be the same in a home therapy setting versus someone who's an in-center hemodialysis clinician versus another department. So trying to have a bit more of idea what barriers we are able to overcome, what are insurmountable. And so continuing education would be one of the strategies to increase that comfort level.
Great, thank you. Marie and Mike have their hands up. First Mike, then Marie, and then there's some more questions in the chat while they're unmuting themselves. You just muted yourself, Mike. There you go, unmute.
I'm unmuted. Thanks, Kris. That was a really nice overview of the work you've done. So thanks for sharing it. I just wanted to comment that I think as part and parcel of or maybe the alignment that's happened as part of the patient experience survey, one of the big areas that came up as a theme both for PD and for home hemo is a lack of understanding about how to transition from not being on home therapies to getting to those home therapies. And I think you alluded to that in terms of some of the survey work that you'd picked up both from the staff perceptions as well as from the patient perceptions. And that's going to be a big area of focus. And I think that actually aligns really nicely with the crash work that you've done as we move potentially into a broader exposure of it. And I just wanted to also add from with Sherry's question, there are many educational components I think that we have developed, but I don't think that we have them in a necessarily a coherent curriculum. I think this is the first stab to try to pull into a curriculum that would be something that would be readily available by health authorities and the programs, irrespective of where they are in the province, trying to have that equity for access to the care. So I think that's part of this. And I think Kris also alluded to the fact that we took a group of people that traditionally would be virtually 100% staying in center for hemodialysis to try to do a different approach with them. And we were able, even in the challenges of trying to start a project during COVID, which is probably the absolute worst time to try to do something like this, that we were still actually able to move some of those traditionally headed towards hemo in-center facility-based hemo to home therapies. So I think it's a signal. I don't think that we have the definitive answer from this because of the practicalities of doing it, but it's certainly a signal that's, I think, worth tugging on for sure there. And that maybe comes to part of Dan's question. I don't know that we can predict what would happen, but we have been really stagnant, at least from the home hemo numbers. We're bringing people in, but our attrition and our intake seem to match one another. So we end up being fairly flat in terms of our numbers. So I think it's exciting to try to do something quite different. So thanks, Kris, for having shared that with us and the work you did.
Yeah, and I guess to agree, there's another question from Kevin, but like this is where implementation science and methodologically trying a systematic way to implement across the province instead of just saying, well, it looks like it works, so please go do it. That doesn't work. And so I think that there's now comes the next thing. So yes, this strategy works. How do you codify it and put it into practice and continue to, I guess not quite, it's not the right word, but babysit it so that you don't just, it requires ongoing nurturing like any other program. So I think, Marie, you have your hand up. That'll be our last question. Short question, short answer. Marie, over to you.
Hi, in interior health, we don't have nurse navigators. I was wondering, in interior health, we tend to use our vascular access nurse quite heavily, both for fistulas, lines, and PD catheters. And it seems to me we could maybe figure out a way to integrate this role or educational program in with the vascular access nurses. Either they do the education and we increase the scope of their role and the number of vascular access hours or positions, or it's a tag your it program where the vascular access nurse identifies the patient that has to undergo the crash program and then has designated hemodialysis nurses or I guess it would be hemodialysis nurses that are capable of delivering the program. I was wondering about something like that.
Yeah, I think that's definitely a good observation, and where we are looking to first define that role and see what the responsibilities would be. And I think that we know that there's some health authorities without the nurse navigator role, and how we could also continue to deliver this. I mentioned the ubiquitous delivery of this and having the standardized education packages and so tools so that anyone could access it really and start the process. And then perhaps we can tag in, as you said, that the backup role and the champion to kind of finalize the key pieces, education, and speaking about barriers. So I think there's ways to adapt it, even without the nurse navigator. I just think you need someone there to help champion it and link it. So
I think, as you said before, it's the clarity of the role and the consistency of the approach, because if you and standardizing it. So yeah, where there aren't nurse navigators, it still has to be someone championing the whole process. Anyways, we're out of time, but obviously very interested and interesting group of people. There was lots of questions and curiosity around it. So we look forward to not just thinking about how to do this, but also systematically implementing this around the province. So you can come back and tell us how each of these things has actually increased in every health authority, even though there's different resources, to Marie's point. So thank you, Kris, for the work you did and also for taking the time to prepare it.
Thank you, everyone.
Have a happy Friday.